Well, welcome now to the history taking presentation of this first CAL. Um, and so we'll just move into it. The first history that we take is the medical history. And we're going to use in this particular prac session in the clinic a written sheet. It's an official hospital sheet prior to when they got the medical history onto the computer system. Now, there's two reasons why we're going to be working on paper. One is that we can't access the hospital computer system because you're not registered patients of the hospital. And two, because they're actually editing it and changing it at the moment. So when you get into second year, there'll be a presentation about the computer system right at the beginning of the year. And if they've got that new medical history questionnaire completed, they'll introduce you to that at the time. So we're putting everything on paper. It still is a valid form, and there'll be areas where you may work either here in Australia or somewhere around the world where they don't have computer records at this stage. So you'll need to know how to work on paper anyway. I'll just explain the sheets as we go through. You had them in the lecture with Dr. Pretty, and this is the front page on the left, and we have on the back this other information as well. So we'll go through, and you're going to actually apply this questionnaire to your patient. So let's have a look first of all. What have we got up here? We've got identification information for the patient here. So it's all made up. It's not a real patient. But first of all, each patient in the hospital has a unique identifying number called their UR number, meaning unit record number. So sometimes it's 6. I think there are many people now with 7 numbers. We've got the family name, the given name, and their date of birth here. So just remember that all of this information is confidential, and it goes into the patient's record. You could never, say, copy it and take it home or anything like that. It's all covered by law. Health records laws, both state and the privacy laws, both state and federal or Commonwealth ones. So we need to be accurate in our recording of all the information. The way the hospital administered this was to give it to the patient, to ask them to fill it out, and then they would come in, not to students, but they would come in, to the qualified dentists that work on the first floor. They'd bring it in, and then the responsibility is of the practitioner to verify the information that's there. So from my point of view, there was no point in getting the patient to fill it out because you have to identify that the patient has understood the question. Now, if they've just circled something, you really don't know that they've understood it. So the best way to do it is to ask them the question yourselves, and then write down any information and clarify things if the patient needs clarification to be able to answer the question. Okay, so we've got it's in confidence, being confidential. Please answer all of the following questions. If you are taking multiple medications, please obtain a list from your attending doctor or specialist to assist in the future dental treatment. Now, that a lot of our patients are older with healthcare cards, and unfortunately, a lot of them take many medications and have many medical conditions. And so it is a good idea to actually get a printout from the doctor if possible, because your patient may not be able to just give you adequate information when you ask the questions. So that's a good thing, even though we don't give the questionnaire. I don't sort of suggest you give the questionnaire to the patient to fill out, because sometimes they fill up all the spaces that you want to write in, and all sorts of things, all problems can occur with that. But you could suggest to the patient that they bring in this list from from their attending doctor, which will help you fill out all of the information that you require. Okay, if you're unsure about anything, please discuss. Well, as I said, best to do it before. Now, there are situations where patients do not either read and or speak English, and so you may have to have this administered with an interpreter present to be able to assist the patient to understand what the questions are asking, and also to assist you to understand what the patient's saying. So those sort of things will all be determined when you contact the patient over the telephone to make an appointment. And if you're finding that you can't communicate adequately with them over the phone, you ask them, would they like an interpreter? And I would imagine they'll say yes if they're having problems too. And ask them the language so that you can have an interpreter booked and ready there at the appointment to assist you with this. Okay, so you've already had this discussed in the lecture and explained. I'm just going to go through how this might run for you with a patient. So it's a made-up patient. Okay, so we'll just move on. It's Dorothy Smith. She was born in 1956, which means she's about 67 or so. So we always keep that in mind. And the first question: have you stayed in hospital or had an operation or a general anaesthetic? If the answer is yes, please specify details and approximate dates. Okay, so in this case, yes, after we asked the patient that question, they said yes. Make sure you circle the answer that they give, and also give the details. So in her case, she had an operation when she was 6 years of age, which would have been around about 1962. So instead of saying 6 years of age, you might write tonsillectomy in 1962. You wouldn't write something like, say, 5 years ago, because you don't know which point in time someone's going to read this. So yes, you're recording it now, but that remains part of the patient's record. And we need to sort of get an idea. We might look at it 10 years later. And 5 years ago isn't, we're 2022 now, so 5 years ago about 2017. But 10 years on, 5 years ago is 2027. It's not the same. So that's one point that you need to be aware of. It's either the age of the patient that you write down, or the year that the operation or the condition occurred. Okay, so the other thing is we always write the most important word first. Remember, we said we've got to be accurate and succinct in all of our recording. So the most important thing is to know what the operation was first. Okay, so the operation was a tonsillectomy. They had their tonsils removed, and then at age 6 years. So, or in 1962. So we go on to the next question. Have you ever had any serious problems after dental treatment? So the sort of operative word here is serious. Okay, so we're talking about something fairly significant. And also remember that we always follow up any yes answers to give more information about the situation. So let's find out what happened with this patient with that question. And they said no, they didn't have any serious problems they've never had any serious problems after dental treatment. So we don't have to write any details because there aren't any. Now, they might ask you, what do you mean by serious problems when you ask that question? So you could clarify it. The sorts of things we're thinking of was maybe severe pain when they went home after the procedure. Maybe their face became swollen after the procedure when they went home. Maybe they had uncontrolled bleeding after the extraction that you did, or they've had at another time, not that you've done at this point. These are all things that may have happened after some dental treatment. So if they've happened, you'd put a yes and you would specify exactly what it was. So the next question is, do you have diabetes? Let's see what happened with our patient. Yes, the answer was yes. So we follow up, and they had type 2 diabetes since they were 42 years old. So we can do our calculation there and say, well, okay, or you could once again, put the year that they had they developed the condition. So they've had it. We do a mental calculation now whenever they tell us things. They're 67, they're 42, so they've had it for about 25 years. Okay, so we always try and match up data as we go through to try and put things into a sort of a chronological context to help you understand what's been going on. So, 25 years ago, they developed type 2 diabetes, or they were first diagnosed with it. Just a brief note that it's controlled, okay, and they have metformin, a medication, and they also control it with diet. Next question, have you had any kidney problems? The question after that is, do you smoke? If yes, approximately how many a day? So we'll move on and see how those two questions go. Well, they haven't had any kidney problems. And no, they don't smoke. The question, do you smoke, is in the present tense, meaning now. Are you currently smoking? No, they're not currently smoking, but as we've asked some more questions, and you may not even have to ask any more much, they may say, no, I'm not now, but I used to. And if they do say that, then you need to find out what their smoking history is. And this person's told the dentist, but they used to smoke 20 per day, which is, a heavy smoker, from age 70 years of age to 45. So they've stopped at the age of 45, but they smoked for 28 years, a heavy smoker. So we keep that in the back of our minds as well. So they've been stopped smoking for 22 years, but they smoked for a considerable period when they were younger. Okay, next question. Have you ever had any type of heart disease, including high blood pressure, heart murmur, rheumatic fever, or do you have a pacemaker? What have we got here? So the answer is yes, we've got something. Now, always circle here the condition that they have. So they have high blood pressure, they haven't got a heart murmur, they haven't got rheumatic fever, and they haven't got a pacemaker. Okay, so it helps us narrow it down just by, we can see that circle really easily, so we can focus on that. Okay, we've got somebody with high blood pressure. What information did we manage to obtain? Once again, it's controlled by medication, and we've named the drug atenolol, or the brand name Tenormin. Yeah. Next question: do you bleed excessively when you cut yourself, or do you have any bleeding or bruising problems? After that, have you ever had a stroke, suffer from fits or epilepsy? Are you suffering from memory loss, or have you been diagnosed with dementia or Alzheimer's disease? Okay, what have we got from those questions? Now, in our case here, we got a no for each of those questions. So we'll move on. Our next question was, have you ever had tuberculosis, asthma, or other breathing problems? And we've got a yes, and we've circled the one here that's mentioned, asthma. If they've got something that's not here to circle, we'll make a note of what that is first and then get the information about it. Now, we've already got the word written, so we just circle it, so we know it's asthma, and it's controlled by Ventolin, takes as necessary. It's only mild and the patient's never been hospitalised. So we're getting an idea of the severity and how often the patient has the breathing problem. The next questions we've all got no's to, but just to go through to remind you what they are. Do you suffer from any liver problems? Do you have any joint problems, arthritis, or a history of joint replacement surgery? Do you have any behavioural or psychological issues? I've got to say, I don't like the word issues. It's like, have you got any issues? It doesn't sound great. I'd say problems. Do you have any behavioural or psychological problems? Is the best way to put it. And for women only, are you pregnant or breastfeeding? So we've got no's to all of those. So what you need to do as you go through is kind of tuck all that information away in your memory, in your mind. So particularly the most significant ones, and we'll have to have a think about what's significant, but we know we've got a diabetic. They used to be a smoker. They've got high blood pressure, but it's controlled with medication, and they get the occasional breathing problem, which they control with Ventolin. Okay, go over to the back of the page, and we look at the question at the top there. Do you have a pressure or bed sore that is currently being treated, or are you at risk of developing them? If yes, clinician to complete the pressure injuries risk assessment. Now, why are we talking about bed sores here in a sort of just a dental clinic where people aren't staying overnight and not going into beds? Well, it's all related to the accreditation process for hospitals, which I mentioned in the lecture, the Australian Commission for Safety and Quality in Healthcare. And one of their criteria is management of pressure and bed sores, which is really related to, hospitals where patients stay overnight. And also the falls risk is sort of related to it, although it can happen in hospitals, as in our hospital as well. You can see you've got extra forms to fill out if patient answers yes to either of those. We could have quite a few patients coming in, maybe on walkers or elderly patients who may have fallen in the last 28 days, and we have to care for them and make sure that we're beside them so that we can steady them if they're a bit unsteady on their feet and so forth, and find their way to, out of the hospital to their car or something like that. So we just have to make sure that, that we assist them in every way to prevent any further falls while they're at our appointment. Do you have any other medical or disability problems that are not listed? For example, physical, sensory, or intellectual disabilities. So something like autism, developmental delay, maybe they're not so mobile for certain reasons, and they can tell you about problems, injuries. I can tell you that one other thing that's not on this questionnaire that I always ask is, have you ever had an accident involving a blow to your face? Because that can cause some problems with obviously bones and soft tissues in the face, but also teeth. And it's a good idea to be able to get that information, sporting accidents or something like that. Past ones we're talking about here. They're not presenting here for an emergency because they've just had an accident on the football field or that sort of thing. When they come to the DTC, they might come to hospital emergency department with something like that. But it's a good idea to understand whether there have been any blows to the face as well. Now, the next question, do you have any allergies or had a reaction to medicines or latex? So latex is specified. Remember, the sorts of things that we might have as latex in our practice. Gloves, well, we don't use latex gloves anymore. We're using the nitrile. But rubber dam, sometimes there's rubber. But you can get non-latex rubber dam as well. So you just have to check that the rubber dam that's there in the clinic is not a latex one if you have the patient who has a latex allergy. Okay, so if they've got the latex one there, you have to ask one of the DAs to obtain a non-latex rubber dam for you to use. Okay, so what happened with this patient? Have they got any allergies? Well, yes, they've answered yes. They're allergic to penicillin. So we follow that up and we're asking what sort of symptoms do they get? That's the logical question. And in this case, the patient gets a rash. Now, that's an indication that the patient has a true allergy. And if we gave penicillin, they could be at risk of anaphylactic shock, which could be death, could, in worst instance, result in death. So it's a very important point. If patient says they get diarrhea or something like that, that's not necessarily indicative of a true allergy. You'll get all of this information, whatever you're recording, checked by your demonstrator, and they will follow up all of these answers as well to double check that your information is accurate. Next question, have you taken any medication for cancer, including receiving radiation therapy or chemotherapy? Now, this is a huge question, and I would never ask any more than that in one go. So, have you taken any medication for cancer, including radiation therapy or chemotherapy? Then I would ask the next section and say, have you had any medication for osteoporosis or any other bone or calcium problems in the last 10 years? Okay, so because it's just too much, it's too complex a question to ask all in one go. And they're all very important points to make sure that you get clear and accurate information. So for somebody with radiation therapy, we want to make sure that we're not going to expose them to osteoradionecrosis by extracting a tooth in the radiation site if it's in the head and neck region that they've had radiation therapy. Okay, so yeah, it's very important that we get that information accurately. Are you taking any anticoagulants or taking any medicine to thin your blood? So once again, if we were doing an extraction, we don't want continuous bleeding. We want them to clot. Definitely we have to be aware of any blood thinning types of medications and manage it. I'm not going to talk about the management and what we would do if we needed to do an extraction. You'll learn about that later in the course. And are you currently taking any medications? Or have you taken any in the past 3 months? If yes, please specify below. Okay, so we've got here the medication, the dose and the frequency. So we've already taken some information about the medications that the patient's already currently taking. So we'll be able to fill this out. We may need some extra information about the dose and the frequency. So let's see how our patient answered. They didn't have any medication for cancer. And they don't have osteoporosis or any other bone or calcium problems. They're not taking any anticoagulants or blood thinning medication. And are you currently taking any medication or have you taken any in the past 3 months? The answer is yes. So yes, they've taken their metformin for diabetes. They're having 500 milligrams twice a day. And Ventolin, when they take 2 puffs from the puffer as necessary. Who would you like to contact? You would normally fill this information in. I haven't bothered at this point. So when you have a real patient, yes, you have to get this information, this type of information down, who their GP is and their contact details. Are you the patient who needs to sign, or are you the guardian if the patient's under 18 years of age. The guardian is the person who'll sign. So that's all around the patient. That's the patient type of information. Now we need to, now we need to identify the clinician. Now, while you're asking all of the question and doing the recording, you're not actually the clinician. Your supervisor is your clinician. And so it's their name that goes down. They take legal responsibility for this information because you're not qualified. Okay, so you can't take the legal responsibility. So demonstrated, that's why they go through things very carefully, because they're legally responsible. So you would write it down, their name, Dr. So-and-so, just in block letters so it's easy to read. And then it's the clinician who would sign it, so with their signature. Everything's always dated so that we know exactly when this information was valid for. And here you can see sometimes they do some follow-ups here, record follow-ups. So maybe 3 months' time you see the patient, you ask again, and it'll be signed off. If there are changes, then you would fill out a new form. If there are changes to the medical history between say this one and one 3 months later, we would regularly, normally the hospital would expect a completely new medical history taking after 12 months anyway. So just to make sure that we become aware of any changes that occur. Okay, so after we've got that, we also have a summary sheet, and we have to reflect on the information that we've got and write it down on this form. You can see it's blank. You've got to put the date. Everything's got to be dated. You would fill out also the patient's details so we can identify who this information's about. You would write things down. So we have to think about what is the most significant information. We reflect on it. So what would be, something that might give the worst case scenario? Well, I mentioned death from anaphylactic shock, didn't I? That would be the worst case scenario for this patient, dying in the chair because we've prescribed them and asked them to take some penicillin in the chair. That would be our worst. And just think about, how significant each of these problems that the patient's presented with, or medical conditions, and how it may affect your management. So we then make our summary. So for this patient, you can see we've filled it in, we've got the date. The most important is their allergy here. So that's there. Penicillin, they get a rash. The medical conditions, certainly diabetes and is a significant one. It's one to think about too, because it can affect oral health. So that's one reason why I've put it top of the list here of the conditions. High blood pressure is important to understand what's going on there. We've got that it's controlled and the medication. And asthma, look, it was mild, so it's the last one. We're probably not expecting an asthma attack during our treatment, but we keep it in the back of our mind in case we have a patient who's got develops difficulty in breathing while they're in the dental chair. So we've got it recorded so that we are ready to respond if we need to. Although we've got those medications in this area with the medical conditions, we would also make a list of the medications so they're easy to access if we've got to look quickly. So we don't have to read every line and everything. All of the significant information should be put here against the line. This is our scan line as well down here. So I can have a look here. Instead of having to read along the line to try and find out we're looking at allergies, I've got it here right against the line. Allergies, medical conditions, medications. Okay, I can find those quickly, as opposed to medical conditions and then having to search through here and try and find the medication here. Okay, so while it's repetition, we're also thinking of how we're going to use this information and how quickly we may need to access it. Now, the other thing we can, so we're grouping our information together in under logical headings at this point. Operations, yes, there's only the one. And why have I put it last? Because it was so long ago, when they were only 6 years of age. Clearly they haven't had any problems from it. I keep that in the back of my mind because I'm not expecting to see tonsils when I'm looking in the patient's mouth and doing the intraoral examination. So we're looking for things to all add up all the time. This here is our patient's, the demonstrator's and my fake signature here. At this point, obviously it has to be the real signature of the demonstrator. The other thing that we do underneath that, because who's that? That's Doctor Who. I've got no idea. So we also put the demonstrator's surname, their last name, in block letters underneath, so that we know who that belongs to. Okay, so this is an important thing to reflect on what that information is, get it in your head, think about how it may affect what you're doing, particularly once you've done your clinical examination. Go back and have a think about these. Does this patient require penicillin? After I've looked and done the clinical examination, I may find a condition that requires some sort of antibiotics. I come back here, double check, no, I can't give them penicillin, so what's my next best drug, and so forth. So we're always cross-checking, thinking. It's not just as we do that, get it signed off, and then we forget about it. Each thing we have to understand what's going on with our patient and then apply it where we need to. So the next thing's the dental history, and we have actually it's in the clinic. It's a university form. It's a Melbourne Dental School form. It's not a hospital form, where you actually collect your information and write it down, so that it makes it much easier for the demonstrator to check it. If you typed it into the computer's behind where you're sitting in the patient, looking in the patient's mouth and all of those sort of things. It's not very well set up, the space. So we always get you to write it on this sheet. It gets checked by a demonstrator who will sign it over here after they agree with everything that's there. And it's when it's signed that you can then enter it into the computer system. Now, you're not going to enter it into the computer system for this practice because, remember, we can't access the system, but that's what you would do in second, third and fourth year. All the students record their information on this sheet. It's actually an A3 fold out, so there's 4 A4 sheets on it, and the first 2 are for the dental history and the examination. And you've sort of got a prompt list up here on the top. You've got the dental history. We've already taken the medical history and used that questionnaire. The next thing we do is the dental history, and you've got to find the reasons for presenting, the history of the presenting complaints, and the previous dental experience. All of those things are part of the dental history. And the other history is the family and social history. So they're all part of history taking. These are all things that we do in this particular clinical session this year. Now, the next one on the clinical examination, we move on to things like the extraoral examination, the intraoral examination, and then the dental charting, which is on a separate sheet again. It's on the 3rd page of this fold out. So for us at the moment, we're thinking of these 2 sort of blank pages where we record our information. So let's go in and find out about our patient. So first thing is reason for presenting. So always have the date on every page that we record on. RFP, reason for presenting, just underline it so it stands out. Put it right against the scan line again so we see it very easily. And we ask the patient, what brings you in to see us today? and we listen to what they say. They may, talk for quite a bit, and you may have to go back and sort of clarify information to get the information you need. This particular patient presented with two problems, two issues, and we recorded in their own words. We don't change any of the words. At this point, we don't insert any technical, professional terminology or anything. We just write down what they tell us. And later we can start to use professional language, but not in this reason for presenting, because a lot of the clues with their problems are in the words that they use. So we've got our quotation mark here, and this patient had two problems. The first one that we found was that they said that my tooth hurts when I eat sweet things. And the other problem that they spoke about was my gums bleed when I brush my teeth. Okay, so we got two problems, something to do with the tooth hurting with sweet things. So even when they say that, we're starting to think, oh, how could a tooth hurt when you have something sweet? What's going to cause that pain? So first off, I know that I'm thinking about at least dentine, because something in enamel is not going to be sensitive. Enamel is not sensitive. Dentine's sensitive, pulp is sensitive, but not enamel. So I'm thinking, yeah, okay, so straight away I start to think about the types of questions that I'm going to have to ask, and my gums bleed when I brush my teeth. Okay, so our next thing that we need to look at is the history of the presenting complaint. So we ask questions about each complaint or problem separately, so that we don't get confused and the patient doesn't get confused. We'll move on. So we've got our next line, history of presenting complaint. Now, one point I'd like to make about written records, we don't leave gaps or spare lines in between. The reason behind that is these records are a legal document, and we can't go back and insert information later. Okay, now why would someone want to do that? Well, maybe after a course of treatment, the patient decides something's gone wrong, and they send you a solicitor's letter and they want to sue you about something. You can't leave a gap, so you can go in and sort of backtrack and kind of what we call cook the books, try and put the information in that should have gone there that you missed. Okay, so that would be illegal. And one of the important things is we don't leave the gaps here. So history of presenting complaint, and then we're on to the next thing. Now, you'll remember from the caries risk patient in cariology, they had a couple of problems as well. And we had this sort of particular way of recording, so that the top problem here, the top point, the reason for presenting is the top point, so it correlates to the top point in history of the presenting complaint. And the top reason, the second one in reason for presenting, correlates to the second point in history of presenting complaint. Once again, that just saves you a bit of time searching for things and it doesn't get confusing. So when we asked our questions about the complaint, about the pain on sweet, so first off we're thinking, well, how long have they had the problem? Where is it? How severe is it? We already know that just from their presenting complaint, that the initiating factor is sweet. Okay, if not, if they said, oh, I've got a pain at some point or somewhere, you try and find out what elicits the pain. So that you'd have a question about that, but they've already told us what elicits the pain. You might ask, does anything else elicit the pain? So maybe cold foods or drinks, or very hot foods or drinks, or something like that. We could ask those sort of questions as well. So the information that we get, you can ask these questions, keep the answers in your head, and then write down the information accurately and succinctly. So what we've got from here, from our where, what, why, how, and severity and those sort of things, we've got that the pain has been there or it occurred for the past 2 weeks en suite, and it's in now. Here we can now put our official sort of professional terms. So this is our term for quadrant 1, Q1, quadrant 1. And we can also, they may be directly pointing to a tooth. You don't, and in this case, we say the patient's pointing to the 1-5. So don't just write down the patient's had pain in the en suite in the 1-5 for 2 weeks, because all we know is they're pointing to it. They may be pointing to the wrong tooth. So they're pointing to quadrant 1. They're saying it's up here somewhere, and they're pointing there. They could be pointing to the 5, and it's actually the 6, or it could be the 4, or something like that. So we have to determine exactly where it is, and you'll learn about that in future lectures for diagnosis and so on. So we don't want to jump the gun and narrow things down, our investigations about what's going on, too quickly. Keep options open. They're definitely saying it's in quadrant 1, so we'll write that, but just say that they're pointing to the 1-5. That means, look, it might be the 1-5, but also we know we're keeping in mind it could be somewhere else. Around the severity, the patient's told us it doesn't linger, so they have the sweet thing, it tingles a bit and then it disappears. And this is another indication of severity. No analgesics are required. So usually people will take some sort of medication for pain, 1 when it lingers, and 2 when it's quite severe. Something that's transitory or just just for a short period, usually people won't take any medication for that, because by the time they've sort of maybe got the medication and got the glass of water or whatever, the pain's disappeared, so they don't worry about it. Okay, the next problem. So we're at this next point. I know this one has to relate to the second one here for the reason for presenting. So we've got gums that bleed when they brush their teeth. Now, you'll note also here I've mentioned gingivae, because that's the professional term. The lay term for gingival tissues is gums, and most, I think it's very unlikely that a patient will come in and talk about their gingival tissues. But we can now use our professional terminology here and present in history of the complaint. So the gingivae have been bleeding on brushing, that means when brushing, for the past 6 months. The bleeding's generalised and there's no pain. So generalised means it's in many areas around the mouth. It's not just in a specific area. And it's not painful. So we start to think, as I'm mentioning here, we've got pain from sweet. How could you get pain from sweet? It's related to a tooth. It's in quadrant 1. It has to be something concerning something with dentine or pulp. Can't be related to the enamel. Here we're thinking of bleeding. We're not expecting healthy gingival tissues to bleed on brushing. A lot of patients think it's normal, but there could be some inflammation there. We could have some periodontal disease there. Most periodontal diseases aren't painful. You may have specific condition that might be very painful, but we're not expecting pain in generally from periodontal diseases. So that's the information we've managed to get. Now go to our previous dental experience. So once again, PDE underline right over near the scan line so we can find the point. So the history that we've got is that the patient attended private practice for yearly checkups and until they retired 6 years ago. So remember they're 67, so you think, yeah, they retired when they were 61. has not been to the dentist since retirement. So they've gone from regular yearly checkups and possibly some sort of management on a yearly basis to nothing for 6 years. They used to receive restorations and a tooth cleaning when they went. Okay, so they haven't had any tooth cleaning for 6 years, haven't had any fillings for 6 years. They do have a local anaesthetic when they have restorations. They've never had extractions and they don't wear any dentures. Okay, and we find out also about their oral hygiene practices. They brush their teeth twice a day after breakfast and before bed using a soft toothbrush and Colgate Total toothpaste. They don't use floss and they don't use a mouth rinse. Okay, so we've had somebody who appears, what can we infer here? They've come on a yearly basis and they've attended privately. So they've had in the past while they were working, they had the income to enable them to be able to go to private practice rather than a public dental clinic. And they've been able to go on a yearly basis. So they sound pretty committed to their dental health to do that. Okay, so we're starting now also to think of, okay, so something's been happening in the last 6 years. And once again, they've come to us and they haven't had anything for the 6 years in between. So now they're in retirement. It appears that they possibly can't afford private dental treatment, and they're waiting now for their names to come up on waiting lists in public dental clinics. And this can happen to patients, that it takes them a while to be able to be seen in public clinics. And so things can develop and progress while they're on waiting lists. This may have happened to this patient. Okay, so we've got our information here. The next is the family and social history. So we go on to the next one. It's family and social history. So a patient lives with the husband. She used to work as a secretary prior to retirement. She has 2 children, a boy, age 32, and a girl, 27. Those children have no restoration. So we can start to see that we found out that our patient lived in Melbourne all her life, and we got her interest. She enjoys knitting, reading, and she likes the football, AFL. Going back to her children, we've mentioned that we've had a patient who appears to have been committed to her own oral health, and we find that the children have got sound teeth. They've never had any restorations. We could ask some more information, like, how often did your children, attend? We don't need to go too far though, because remember that it's our patient who's our patient, this person. It's not the children. So you can ask some information. You may not record it all. Maybe she tells you that when she went for checkups, the children went too. They went on a yearly basis. That's possible. These children would have lived in Melbourne during the time when Melbourne had fluoridated water. So we have a number of young adults who've lived all their life in Melbourne with no caries. And in this case, these children have never had any restorations. Okay, what has to happen here is it needs to be signed. It's got to be checked. So your demonstrator will give you instructions on when they're going to come and check things. Usually, probably they'll get you to do the medical history and ask for you to call them over once you've got that information so that they can check before they allow you to move on to the dental history. And then once they're happy with the medical history, they'll give you an instruction to take the dental history. Okay, so they come along and check that. When they're happy with it, they will sign it. And once again, we write the demonstrator's name down in block letters or there as well, so that we know who belongs to that signature. Okay, that's the end of our prac for this clinical session that you're going to have, because the next part is looking into the examination of the patient. So that's the second prac when you're the dentist on the second occasion. What I will point out though is we only have the 2 pages, the page that was on that previous slide and this second one, which hasn't got the little table up the top. So we've got a few more lines on the back of the page. But to this, the front and the back of these has to allow you to record all of the information for the history, dental history, and the examination of the patient. So we don't have any more pages to write down. So you've got to be succinct. You've got to be obviously accurate, but succinct in recording. And my advice is that don't go any further with family and social history than the top 4 lines. Even better, like I managed to on the previous slide, I got the family and social history completed on that first page. Okay, but don't go any further than this, because you won't have enough room on the rest of the page to be able to write your findings from the extraoral and intraoral examination. So you have a third sheet, which you'll see from lectures and from the next cal, with a dental chart on it. So it doesn't look like one of these sheets. And then there's also on the back of the dental chart, on the back of that sheet, is information to help you come to record diagnoses and a treatment plan. Okay, so these are the only ones you've got for your history taking and your extra and intraoral exam. So really think hard about how you record it. Make sure you get the most important point next to this scan line down here, so that you don't have to read line after line after line to find information that you need. Okay, remembering also it's not just you who may have to look at this. It could be, well, it will be a demonstrator, but it could be somebody else who sees your patient in another clinic and they've got to find information from what you've recorded. So you want to be as efficient as possible. The way to do that is to get the most important word first, so that we know what the rest of this line or the next couple of lines is about. And then we find the information or the area that we want the information about. We scan down here, find the word that we need, okay, here we go. We can read across here. Okay, so that's it for that. We've got one more short presentation preparing you for the clinic prac as well.